patient flow, Yaku mentioned something that he's focusing on patient flow but also looking at the clinical design. But what I want us to do is to look at the work practices. What are the infection control measures that we need to improve or to put in place to ensure that we do not expose anyone to infectious diseases, to people with infectious diseases. So let's talk about that. You've already implemented this in your facilities. There's a lot that happened during COVID. So there are some good ideas, things that we can continue with. But also remember that Gregory mentioned something that for you to know which infection control measures, you need to conduct a risk assessment. Otherwise, how are you going to know what to do and so forth? He even mentioned that, in his house, because there was somebody with COVID and then had to move things around and check, which direction is the air flowing. So let's talk about those things. What are the things that we can put in place? Have you ever conducted a risk assessment? You have. Which tool are you using? Are you using the Department of Health tool?
I did occupational health. That's how we have our own.
You have your own, it might be different. Gideon you have done. And have you conducted any risk assessment in your facilities? Do we come from TB facilities? Where we come from? Correctional services, CHCs? It doesn't matter. I have a perfect tool here from the Department of Health. So I will share with you. But there is also another tool that mainly focuses on hospitals. So it is important that we conduct a risk assessment which will inform us that, okay, whatever that we have put in place already, it is working, but if we have not, what are the things that we need to put in place? And what is also important is to come up with improvements. So it's a cycle like that. Any other, how would you improve patient flow in your unit? People use stickers, the other thing, somebody mentioned the important thing about signage. There isn't any signage, but with COVID we had signage again. That from the gate before you enter the building, there'll be red steps, there'll be orange. You go to people under investigation. How come we never had Gati? Because the aim is the same. We wanted to make sure that there's no mix-up of patients. You know exactly that you have been screened there. So from here you are going to get your file. From your file, you don't go to any other waiting area. You go there where you're gonna, you do your vitals. There won't be any signage. So you've removed those stickers.
So these policies are actually there. It's just that they only get implemented in terms of when there is an urgency.
Yes, they're there. The information is there. But the SOPs, how to implement it. We know, they'll say, you'll also like, okay, where's a document that, step by step guides me that this is what needs to be implemented. They'll be like, I know, healthcare workers, they know. They should.
But again, the other thing is, when they come to institutions, it's the manager, everything is asked or requested from the manager, nothing. When they come to the consultation room, it's other than say, Kitibone, can you give us this information? Kitibone is busy with a patient. You see? Then I give them verbally and whatever, they record, they go out.
Yes.
When it's staff meeting, the manager is not saying, this is for us. He's saying, district, do you still remember district came? This is what they are saying we must do.
So I'm not part of it.
So they're
it's
not
like
only...
when you develop your quality improvement plans. What I've noticed, instead of including yourself, it's so easy to say we went to OPD, so the manager in charge there, when you ask, okay, who's the responsible person, it will be somebody else. It will never be the people who are there who are never. It will always be the manager. I'm like, okay, the manager will, oversee and make sure that things get implemented. But who is it? We're not working as a team otherwise. That's why you'll find that certain things, it is the responsibility of the infectious diseases unit. And this is why, even with risk assessment, they'll say it is the responsibility of occupational health.
Yes.
When it comes to healthcare worker screening, of course it is, but needs support from everyone from that team because those people are not coming forward. So when I, as the area manager or the unit manager, what are you doing to encourage people in that unit to go see the occupational health and safety nurse We're not doing anything. We just keep quiet. It is your responsibility. You will struggle the whole year. We haven't even screened half. So if we familiarize ourselves with the policies, the plan, we will know that each year at this time, or look out for those emails, the occupational health and safety person will be doing, and also appreciate why she's doing it. So it's not even about healthcare worker screening, but we're just saying as clinicians, let's get involved and work with the committees that have been put in place. And let's not forget the non-clinical staff. Somebody was mentioning that they have an issue with non-clinical staff and so forth. And I'm like, you treat them differently. You do the fit testing and whatever, but do you do them? You don't. They don't even know. You just dish out these things, and when they know where it, you complain, whereas you make them potters. You put them there.
And they're giving us problems as unions.
As unions, they
Yes,
come to
because
you and say what?
Yes, if we have to represent them, and Kamvus is saying, I've been asking them to test, then we don't win the case. And that's what we are failing to convince our members to say it's very important to do assessment. They realize it when there's
Only
a problem.
then.
Yes. Oh, sorry,
maybe
no?
to latch on to that, it's also in the Occupational Health and Safety Act.
Yes.
So as an employer, there are responsibilities for an employer, there are responsibilities for an employee. And as an employee, you're supposed to subject yourself to medical services. And that includes everything, but TB is part of it. But that's where now there's this gap. And obviously, even the employer is not enforcing it, which is where now the Department of Health is involved. Because that is also that's why cases were lost. Because there are gaps from both sides.
So before we close, Dr. Mphahlele mentioned, I think in her closing, that we need to monitor implementation. How are we monitoring? How do we know it's working or not working? Are there any indicators? You might call it something else, but how are we monitoring? Simple thing like turnaround time. Again, the aim is to reduce the risk of transmission within the facility. So you're like, okay, let's look at turnaround time. A person gets here before even admission at how soon do we collect sputum? That is still infection control. And we want to fast track them to make sure that they are treated and whatever. Do we do that? Do you do? How do you monitor implementation
of the guideline?
Harari, whatever measures that you have put in place there.
Report.
The report of the facility committee.
But are the indicators clear? This is what you need to look at. And
in the guideline, indicators are there.
Okay. And that actually we have a problem with staff screened.
Yeah.
So that one is out. It will always be. That one it won't work. Yes. But I know what people usually look at as, the turnaround or waiting for
Turnaround
or
time.
whatever.
Yes.
Those are the things.
Turnaround time.
How soon you collect your sputum and
yes.
you didn't expect and whatever. So it is really important. Otherwise we just do it just for fun.
But where I am working is within the next 48 hours. But then there are times where the lab won't have the reagent, then it takes
Before you get it. Now, that one is okay. It's understandable. Sometimes they won't have perhaps sputum bottles or there is an issue with that. But I believe it will be communicated. Any other questions?
Yeah, I think in the same breath, sometimes we are used to things not being done well.
Yeah.
And you get comfortable.
And it's so comfortable that the sputum can take 1 week. I know, I'm in private. Sputum within the same day to the next day I get the results. UNE, 30 minutes I get the results. Something that I failed to get when I was in government. I was even comfortable that I did not get the UNE. We'll go and check the UNE tomorrow. And then it comes later and then it's abnormal. All I'm saying is, if you don't clamp down on the services that are being done. NHLS can produce this thing within 24 hours, period.
We need to talk to them. You know, that integration, somebody mentioned integration. You'll be surprised when you go to them. We understand there are challenges, they are serving a larger area, there are other clinics, but when you engage and say, okay, this is a very urgent specimen. You know, we went to another lab, they were like, no, usually with bloods, they will say urgent. But sputum, it's not, so that's why we treat like we said the other day, especially if that lab is not that busy. So they were like, no, if it's really urgent, we can do that, but you know, let's negotiate what can we do to shorten the time. They do listen, so we can engage them. That brings us
And money talks.
This was insightful.
Thanks, colleagues.
At the 7th South African TB Conference in Durban, ETTi presented Airborne IPC workshop. All lectures and exercises can be found on the ETTi website.